near and dear to me. I think most of you know me as an athlete. Never had a serious knee injury, but did play a lot of soccer. And you're going to find tonight we're going to talk about some astonishing statistics when it comes to knee injuries, soccer being one of them. I have also an interest in this because I got young kids, like probably many of you, and also with some of these coaches, you got a lot of young kids who are exposed to some, potentially significant knee injuries. Also, you'll laugh about this. Made it through my entire sporting career without many bad injuries. 4 years ago, I was on the wrong end of a sharp scalpel for an ACL reconstruction. So, I have studied these things, I've fixed these things, I've had the experience of going through what it's like to have your ACL fixed and the rehab and how involved it is. So, again, these topics are near and dear to me. Tonight, we're going to talk about ACL injuries. More importantly, we're going to talk about preventative programs that are out there so that you can help people avoid these things. There are some great programs out there. Julian, Adrian, and I are going to tag team this. I'm going to turn this over to Julian. She's going to tell us a little bit about the anatomy. Adrian's going to talk to us a little bit about the biomechanics of these injuries. I'm going to have the opportunity to talk about surgery, which is something that I do on a regular basis, fixing these things. I had the opportunity to spend a year in a fellowship program with basically the godfather of ACL reconstruction, a guy named Bill Clancy. So if you've ever had your ACL fixed, you can thank him for figuring out how to do this through an arthroscope and just making these small little incisions. After that, Julian's going to take over again and tell us about the injury prevention programs that are out there that can really significantly decrease the risk of having an ACL injury. Because these things are not something that you can take lightly. It takes a long time to recover from these things. So with that introduction, again, I want to thank the coalition for putting us up. I want to thank the high school for giving us the opportunity to use this lecture hall. And with that, I'm going to turn this over to Julie.
All right. So first of all, how many of you have ever or know somebody who have actually injured your ACL yourselves? Yeah, that's what I thought. All right. So this is why we're here. Hopefully, after tonight, we'll have a little bit more information to help you out. So the first thing I wanted to do was to start with this video, and hopefully, we'll be able to hear it.
Look, we're looking to sweep you guys. You wanted us. You were crying out that you bypassed the harder team in Miami Heat.
Rose came down bad on his left foot. See him holding onto his knee and down. He was flying and he came down wrong on the left foot. Now whether it was an ankle or a knee, I do not know. There's Coach Collins out there and all his teammates running, and this with the injury, we just talked about the 26 games he has missed with an assortment of injuries, and now holding a knee late in a game that is already decided for all intents and purposes.
And I'm sure everyone around the country is going to say, wow, why was he in the game?
Let's see how he comes down on the left leg. Keep an eye on the left leg there. Yep, when he planted, that's when whatever happened. Let's see here.
Yeah, it's before he comes down. It's the plant right there on that left leg.
There was some give. There was some give on that knee, and you could see it.
Looked like it went in, too.
That's what I'm saying.
So, and I'm going to go into a little more detail about Derrick Rose and what he had happen with him. But so just to continue on, this is the topics we will cover today. So I will go over what the ACL is and what are the costs of the injury and what it's costing us as a nation in healthcare. And then Adrian's going to go over the causes. Dr. Heidi will go over the treatment, and then Adrian will finish up with rehab and the programs that are available to you and some of the resources that we have. So first of all, what is the ACL? You can see in the middle, it's that band that connects this. I'll come over here to show you. This band right here that connects the top of the femur to the lower leg. You can see it's pretty small. It's right in the middle of the knee, and the main purpose of it is to keep the knee stable, to keep the shin from going forward in front of the upper leg. So what does it cost, as you all just mentioned, that you either know somebody that has had an ACL injury or you've injured your ACL yourself? What is the cost of this on our healthcare system? So there's about 100,000 to 250,000 reconstructions per year. In the past 2 decades, there's been about 1.5 million ACL reconstructions in the U.S. So this number is increasing. And then the $17,000 per case is actually a lower end. That's in all the research that I read, that was even the low end cost. But on average with rehab and surgery, it's about $17,000 per case. And then healthcare cost averages of greater than $3 billion per year. So this is a big deal. So what else is cost of an ACL injury? Also loss from sport. So rehab usually lasts anywhere from 6 to 9 months. Usually it takes people about a year till they can return fully to sport. With Derrick Rose, if anybody followed that, he was physically able to come back before he was mentally ready to come back, and he took a lot of flack for that. And then came back the next season, 10 games in, re-injured, was out again for another season. So not only is it cost of injury for physical, but mental as well, as it can take a toll on that. And then mood disturbances. Obviously, depression is part of the injury process, denial, acceptance, and then finally getting back into the game. But depression is a big issue when you're dealing with an injury, especially an injury this big. A lot of times people lose their identity or feel like they lose their identity when they can't do a sport when they're injured. So also those that are injured or have an ACL injury, their risk for re-injuring that is 25 times greater in the same leg as a previous ACL injury. And then whether they have surgery or not, the chances of having osteoporosis in that, or osteoarthritis in that joint is 10 to 20 years after the ACL injury. So they're showing that that's showing up regardless of what rehab you choose to do. And then also decreased quality of life with that. A lot of times people get nervous to return back to sport, or even people that have a physical job that lose part of their pay from that because they can't return to work if it's a physical job. So there's a lot that goes with this. So the main point of tonight is prevention is key, and that's why we're glad you're all here. So Adrian's going to take over on that.
Thank you, Julian. As Matt previously mentioned, or you saw in the bios, my name is Adrian, and I'm a physical therapist here in town with Alpine Sports Medicine. To give you a quick background, like Dr. Hayden did, of why this topic is so important to me, is myself, I've played soccer since the age of 5, and my collegiate soccer career was quickly halted by an ACL tear. It was my work with a physical therapist to return me to the soccer field that is part of the reason I'm actually a physical therapist today. As a physical therapist, I've gained experience around the country in regards to ACL prevention programs, and I've also stayed up to date regarding new research regarding ACL prevention. So with this knowledge, I'm very passionate about preventing ACL injuries, so individuals do not have to go through what I went through to get back to athletics, or worse off, never return to athletics. So please do not misinterpret this though. I'm always very thankful to help athletes get back to the field, but my true passion is injury prevention. So before, unfortunately, we can jump straight to injury prevention, it is best to understand fully the ACL functions. So we're going to start there. So as Julian mentioned, the ACL is right smack dab in the middle of the knee, and it resists forward movement of the shin bone or backward movement of the femur. Easiest way to think about this is just kind of think of a rope between two bones. So if we pull it too much, that rope can tear. If we don't pull it too much, it can actually stay intact. So secondly, another thing that it'll function to do is to limit knee extension or knee straightening. If you think of those athletes that can hyperextend or snap their knees backwards, that will actually cause more tension through the ACL, something that we want to avoid. And lastly, the ACL also functions to resist the extremes of knee rotation, inward movement or outward movement, meaning with the foot planted, if we rotate, that can stress the ACL. Also, if we allow our knees to cave in, that can stress the ACL, or if the knee goes out to the side, for instance, with a compact injury of maybe a lovely helmet to the knee and a football injury. So moving forward, causes of the ACL, like I mentioned, if you think about that rope, if the stress or the force through the ACL is greater than the strength of the ACL, we can have either a partial or a complete tear of the ACL. So when we think about this in a broad perspective, there are 4 different types of ACL injury. The first would be that direct contact. That means contact directly to the knee. And as you can see in this picture, unfortunately, those are the ones that are often unavoidable. Those are the ones we don't study as much in research because there's not too much we can do to prevent that besides maybe change some rules in sports. We're not going to do. Indirect contact, or contact somewhere else besides the knee. If we use our imagination in this bottom picture, if this opponent that you can barely see in the black uniform right here, as my arrow is indicating, if she was to hit this athlete at her hip, that could cause stresses through her knees. And then as you see on this final picture, her knee is in a collapsed position. Again, potentially an ACL tear. It could also be, if we use our imaginations, a classic non-contact tear, meaning there was no foul, that athlete in the black uniform did not have any contact with her, and unfortunately the knee collapsed and the ACL could tear. So again, classic non-contact is really where the focus is, and we'll talk in just a minute about the percentages of ACL tears with each of these. So classic non-contact, no contact anywhere, and the injury happens. Oops, sorry. So the second picture here is a common non-contact injury with planting or pivoting. So again, it can happen in all sorts of sports. So that's a rugby player, obviously. And other non-contact is the fourth type of ACL injury, and that would be just during simple daily life activities. Those are fairly rare because it does require quite a bit of force, but it's still possible. So with the causes, 70 to 80% are non-contact. That means there's no contact with any other person. So these are the ones that are really highly researched, because why is this happening in our athletes? Common mechanisms are landing from a jump, especially with poor form, so especially with the knees collapsing in. We'll go over all the details here when we get to prevention, but just kind of plant that seed in your head. If you land from a jump with poor form, that can cause it. Changing direction, such as cutting or pivoting. Stopping suddenly or accelerating. And because these are the common mechanisms, the sports with the highest risk include basketball, soccer, football, skiing, and gymnastics. So let's take a minute and watch a couple more videos. I wanted to kind of give you an overarching view, not just that it's only professional athletes here tearing the ACL.
And they're using that speed against them. From the shotgun, run again. Good blocking and turning the corner. Here's to Jamal Charles, who's not that big as running backs go. 199. Jamal Charles is down. He might have hurt his knee, either trying to avoid the mascot or stopping when he hit the mascot. He was well out of bounds. Got that quick little push, got the first down.
That big stride, he heard something.
Yeah, he might have kind of had a little high-speed wobble, and I sure hope he's okay. It's such an exciting football play.
We won't watch the misery of it. Okay, so obviously there's a lot of factors that go into these injuries. So as Julian mentioned, I don't know if you mentioned or not, but I'll throw it out there. Maybe on your flyers you found out that female athletes are 2 to 9 times more likely than male athletes to sustain ACL injuries. Because of this wide disparity, extensive research has been dedicated to this topic of risk factors. Why is this such a big disparity? So first they looked at anatomical factors, such as variances in pelvic size and shape. So as females go through puberty and they get a wider pelvis, their alignment of their femur thigh bone can change, and therefore the alignment of the knee can change stresses through the knee and change stresses through the ACL. Second, they looked at intercondylar notch width, big fancy term of saying where this ACL lives. You can see my arrow right here, right in between these 2 large condyles in the femur is where the ACL is. If you can imagine that notch width being smaller, basically allows less space for that ACL, and therefore could increase the risk of ACL injury. Size of the ACL. When standardized for body weight, females' ACLs are smaller than males, so that could play a role in it as well. Ligamentous laxity. I mentioned briefly before about how the knee is going into hyperextension or a snapped back position, as the athlete on the left demonstrates. That can put more tension through the ACL, more stress through the ACL, and therefore increase the risk of ACL tears. Q angle or quadriceps angle has also been studied. Basically, the muscle here in the front of the thigh, that quadriceps, varying angles of pull could also increase stress or strain through the ACL and through the knee. And lastly, body mass index. Higher body mass index has been shown to have increased risk of ACL injuries. But again, when we kind of take a step back, body mass index is the only one out of all of these that could be modifiable. So even though these have been studied, they're kind of less conducive to intervention. So we're going to look over those. Hormones, of course, male versus female, it's always hormones, right? Some studies show increased risk during the pre-ovulatory phase of the menstrual cycle. Others show no connection. So the current research right now is that there's no conclusive link between ACL injuries and a predictable time in menstrual cycle. Environmental conditions, of course, this definitely goes male and female. We've got weather, playing surface, and footwear. When we take all three of those combined, all three of those have to do about the friction force between the shoe and the surface they're playing on. As I mentioned previously, the ACL will limit the extremes of rotation, but if that friction force between the shoe and the surface is too high, it could put even more stress through the ACL. Things we want to look at. Just kind of a side note, ACL injury rates in indoor soccer, much higher than outdoor soccer. Something to think about, what friction forces are changing between indoor and outdoor soccer. And knee bracing. Some orthopedic surgeons will prescribe a brace after athletes have completed ACL reconstruction, but at this point, as far as prevention goes, there's no conclusive evidence to support that brace to prevent it before needing an ACL reconstruction. Okay, so now we're starting to get into the stuff that's modifiable, things we can change, right? So first of all, strength imbalances or deficits, especially when between the hamstrings and the quadricep muscle and the core. So let's dive into that a little bit deeper. As you can see on this picture, the left my arrow, this quadriceps muscle is in the front of the femur or thigh bone, and contraction of that will pull the tibia forward, as demonstrated by this arrow. With that, it will put increased tension on the ACL. The hamstrings, or this muscle here in the back of the femur or thigh bone, will pull the tibia or the shin bone backwards, which will slacken the ACL. So many female athletes, their quadriceps are stronger and also turn on first before the hamstrings. That causes more tension on the ACL because that strong dominant quadricep is pulling the tibia forward. So really what we want is a balance between the strength in the quadricep muscle and the hamstring muscle to provide stability to that knee instead of these kind of a tug of war on that rope with an ACL. Okay, so we're looking for a balance. I also mentioned core. There's been up and coming research, and a lot of new research dedicated to strength in the abdominal and back muscles to help support where the body is so that it doesn't change the forces on the lower leg. Again, we'll touch base on that later. Other risk factors, big one on all the research is this neuromuscular control. Big fancy way of saying the brain's ability to control muscles, which of course inherently control where the body is in space. As you can see by these pictures down at the bottom, the brain's ability to control this knee from not collapsing inward on the left, or you see this lady having her knee collapse inward here versus neutral alignment on the left picture. So we're really looking at how the brain can control that. It's not only a strength issue, it can also be the brain's ability to control where those limbs go. Interesting point is there's a divergence in this ACL injury rate between males and females at the age of 12, which is commonly around female puberty. So these females are going through rapid growth, but they don't necessarily have the increase in strength as well as this body control and body awareness to go along with that increase in height. You might see this as awkward movements. I was definitely one of them, right? Middle school athlete having awkward movements as you're going through those growth phases. Males, on the other hand, have an increase in testosterone, which a lot of times evidence that this is the primary risk factor for girls, this neuromuscular control. This can be modified. So this is what we're going to look at further in prevention, as well as strength imbalances. Of course, we can improve strength. So this is kind of the take-home message of risk factors of what we need to focus on. So hopefully after that we have a little better understanding of some of the risk factors, the causes and the costs of ACL injury. And now Dr. Eric Hayden will discuss some of the treatment options.
All right, so I can tell you, I hate being in the clinic, in the examination room, and I'm the guy who has to bring the bad news. Classic history, you know, I was doing something, I felt a pop in my knee and my knee swelled up. Those are the two things that we're often very interested in hearing about. If you feel a pop, and if you notice that your knee swells up within the next 12 to 24 hours, chances are you probably injured your ACL. And very often, if you've had experience, you've had friends who've done this, when I tell somebody it looks like you've torn your ACL, I can tell you more often than not, you see tears in their eyes because they know that it's going to be an extensive rehab. They're going to have to probably go through surgery if they want to get back to doing their sports. It's a lot of involvement. So, again, you know, we're looking at this ACL. That thing's missing right there. So you felt that pop. There's a little artery that sits in that, fills up your knee with a bunch of blood. So, management options. You got the non-operative, you got these extra capsular reconstructions, you got primary repair, and then you got reconstruction where you take out the old ligament and you put in something new. Non-operative, for most of us who are involved in cutting, pivoting sports, probably not the best option, but if you are somebody who is doing something straight ahead, if you are riding a bicycle, you can probably get by without your ACL. You don't have to go through any surgery, you don't have to go through the rehab after. These extra capsular repairs, I'm going to tell you that's of historical significance. That's what we tried to do before 1980 when we finally figured out biomechanically how important that ACL is and how important it is to put that new graft that you put in that knee in the proper spot. But before we used to try things like taking your iliotibial band and wrap it around your tibia. Again, to keep your tibia from sliding forward. Basically try to do what the ACL has now lost the ability to do. Primary repairs. Before 1980, we used to think, gosh, can we whip a couple stitches in this thing and then tack it down to the bone where it belonged? Did not work. Reasons are numerous, but the bottom line is, the thought is, the environment within your knee, inside the knee joint itself, is such that it does not allow the ligament to heal. If you injure some of the other ligaments around your knee, like your medial collateral ligament, which is another one that you often see with cutting, pivoting sports, that will heal. It's outside your knee, you just got to rest it. Sometimes you got to wear a brace. But primary repair of ACL does not work. There have been some guys who have done what they call a healing response. So they will go and kind of poke the bone where that ACL is kind of pulled off, the thought that that would work. I've seen the ACL heal down to there occasionally, back to that spot where they poke the holes, but stability-wise, functional, subjectively the patient goes, yeah, my knee still feels loose. So, 1980, they figured out how to reconstruct these things through the arthroscope. Prior to that, it was a big open procedure. You know, if you have some friends, gray hair like myself, you probably see big incisions around their knee. We figured out that you got to take out that old ligament and put in something else. So the question is, what else do you put in there? So graft options. You come to my office, tears are rolling down your eyes. You want to get this thing fixed, you have to figure out what kind of graft to use. You know what it reminds me of? I just got done shopping for a car. You get on the internet, you kind of push a button, I want this option, I want that option. Well, it's kind of like that with ACL reconstruction. What kind of graft do you want? Prosthetic grafts. This is something of historical significance. In the early 80s, for about 5 years, we used to think that Gore-Tex grafts were the graft of choice. You didn't have to harvest a graft from another part of your body. At that time, we did not have the ability to use cadaver grafts, so they used these Gore-Tex grafts. Worked great for about 5 years. And then at about 5 years, all of a sudden, these things would just blow up. And as a consequence, you ended up with a large effusion and inflammation in your knee, and then to take those out and to put in something else became very difficult. But for about 5 years, it was sort of the graft of choice. Great marketing tool. I'm not going to take any of your tendons. I'm going to use a Gore-Tex graft. Unfortunately, these things, long-term, after 5 years, we realized these do not work. So then we started looking at other options. First one is autografts. Autografts are using your own tissue, and there are a bunch of options. More recently, over about the last 5 to 10 years, we've gotten very good at using allografts, which is basically cadaver tissue. And cadavers, they're willing to give you anything that you want. I'm not going to complain. So, autografts. ACL reconstructive surgery. This was sort of the graft of choice. And this is the graft that was described in the original arthroscopic procedures. And you ended up taking a piece of the patellar tendon, the middle third of it. This is what that graft looks like, all right? You see a piece of bone here, you got the tendon, and then you got another piece of bone. And you got these sutures in it so that you can basically pass it up through the tunnel that you ultimately made. Hamstrings became more common, and the reason was because after you harvest your patellar tendon, the biggest consequence or complication was anterior knee pain, because now you've got only 2/3 of that tendon trying to do what the entire tendon used to do. The other thing is you would close up this gap, so you put some stitches in that tendon to close that gap that you made in that tendon now. And as a consequence, the height of the patella would start to come down a little bit. So biomechanically, the patella was not in the spot it used to be in. So people would complain about anterior knee pain going through the rehab,
And down the road, they'd say, you know, my patellar tendon is kind of bugging me, or my kneecap is kind of bugging me. So we started heading toward using hamstrings. Hamstrings, you're going, gosh, you know, why does that make sense? And I'm still sort of, for me, the jury is out of why you would use your hamstrings. Because if you looked at the anatomy in some of those earlier pictures that we saw, your hamstrings are basically dynamic stabilizers keeping your tibia from sliding forward, which is what your ACL, now that it's been torn, isn't doing anymore. So you got these dynamic stabilizers that potentially you're going to harvest and use as a graft. But this is still a pretty good graft. Hamstrings are pretty good grafts, and they're still used a lot today. There's a good study done in Sweden where you got socialized medicine. You can do some big, large studies looking at the number of people who have had ACL reconstructions. In their elite soccer players, this was sort of a graft of choice. But if you ask those guys questions about, you know, how do your hamstrings feel? Most of those guys would say, you know, a couple of years out, I still feel that pull in my groin, you know, just like I'm going to pull my hamstrings. So those are options for autografts. Because of some of the consequences of using your own tissue, we've now started to use allografts. That's cadaver tissue. And they can come from all over the place. You can get bone patellar bone, you can get Achilles tendon, posterior tibial tendons, anterior tibial tendons, peroneal tendons, you can get even hamstring tendons. And all you do, you know, you start the procedure, you look at the size of the knee, you say, okay, I want an 11mm graft. You go in the refrigerator, and there's a bunch of options of 11mm grafts. It's the greatest thing. And these grafts, people worry about, you know, what's the immune response, or, you know, what's going to happen? Are you going to get an infection? Musculoskeletal tissue is pretty unique stuff. You do not really develop much of a inflammation or reaction to musculoskeletal tissue. Now, the one thing you got to watch out for, people have gotten very good at cleaning this tissue so you don't have to worry about transmission of diseases. So, cadavers, they'll interview the people who know this person, make sure that there's not some unusual habits that may lead to transmission of disease. Then they will take the graft out and they will then basically try to sterilize it. There are companies that have proprietary ways of washing the graft. One of the more common ways is irradiating the graft. You do not want to use an irradiated graft. And that's one of the more common ways of sterilizing grafts. If you're having somebody fix your ACL and they're going to use an allograft, do not use an irradiated allograft. The problem is it messes up with the triple helix design of the collagen. It disrupts the triple helix, and ultimately those grafts fail. So if you're going to have somebody use an allograft, ask them where they're getting their allograft, ask them how they're sterilizing that graft, and if they say it's an irradiated graft, tell them you want to use somebody else's graft, because there's a bunch of different companies out there. Find somebody who is willing to use a different type of graft that's not irradiated. But again, allografts have kind of, over the last probably 5 to 10 years, become more and more common. That's what I went for. I went for a allograft when I had my ACL torn. All right, so you got to figure out what the options are. You got to figure out what kind of graft you want to use. Surgery, graft placement, first on the tibia. This is one of the tibial drill guides, and there's a little area in here. There's a little guide, and you put that into the knee. You have a trocar, or a cannulated tube that goes up to the tibia, and then you got a drill that you drill up to match that little guide you got sitting inside the knee. If you got it in the right spot, you then take a big reamer that's about a centimeter in diameter, and you make a centimeter or a 10 centimeter hole, or 10 millimeter hole, or you make it about 11 or 12 millimeter hole. The bigger the hole, the bigger the graft you can put in. So graft placement on the tibia is important. More important is the graft placement on the femur. You want to try to get it in its anatomic origin. And that's been something that we have been troubled with really since we first started doing these ACL reconstructions with an arthroscope, because you were drilling the femoral tunnel up through the tibial tunnel. And you can see how that tunnel, you got to have a straight line up through into the femur if you're going through that tibial tunnel. The real
attachment on the femur is more down in here. The question is, how do you get that attachment down here? Well, a couple companies have come up over the last couple of years with some unique femoral guides. And this one is made by a company from Arthrex. I have no relationships with Arthrex, but this is a very cool device. You have a guide that goes into the knee. You find the spot on the femur you want. You send in a drill. The end of that drill, you can actually expand the end of that drill. So you send it in, it's maybe 2 or 3 millimeters in diameter. You get it into the spot you want. It's inside the knee. The very tip of that drill, all of a sudden you hit a little button. It becomes a 10 millimeter reamer. So it goes from 2 millimeter diameter to a 10 millimeter diameter. You want 11 millimeter, they got 11. You want a 10 and a half, they got a 10 and a half. But the cool thing is, it lets you put that graft right where it belongs on the femur. And when we have to occasionally do revisions, the biggest problem is finding the graft kind of stuck up on the top of the roof. The graft has just been put in the wrong spot on the femur. It's probably the biggest complication that you see leading to revision. So this. All right, so that was quickly about surgery. Rehabilitation, and I think Julian's going to get into this in a lot more specifics, but here's the thing you got to do. You got to respect biology of healing. These grafts basically take 3 to 4 months to heal the bone. During that time, your goal is just to get the bend back in your knee and to protect that graft. Don't twist it, don't stress it, don't stretch it out. Those things get as weak as you're ever going to get between about 6 and 10 weeks. And very often when I'm dealing with high school kids, they're about 6 weeks. I go, man, I'm feeling good. I'm going to go play basketball with my buddies out in the driveway. And I was like, please, make me look good. So first week to 12 weeks, range of motion, protect the graft. After 12 weeks to 16 weeks, you're getting back into your functional training. Okay, so you're getting back into the sport. Return to sport about 9 to 12 months, but as you heard, a lot of the literature now, if you look closely, objectively at measurements of your skill level, it takes you 2 years before you are back at the same skill level you are before you left the sport from that injury. You might get back in 9 months where you're playing the sport again, but when it comes to really getting back and participating at that same level you were at before, it is 2 years of hard work before you're going to be playing that sport again at that same level. All right, last picture I wanted to show. I am a big fan of the bicycle. Spent a couple of years riding with the 711 team, and I put this picture up here because, I said, if you're into a sport, sometimes you don't need your ACL. This is one of my colleagues that I raced with, who was a Norwegian paratrooper, jumped out of a plane, dislocated his knee, so he blew out 3 of the 4 ligaments in his knee. If you examined his knee, if he came into my clinic, I'd say, dude, you need your ACL fixed, you need your PCL fixed, probably even cinch up your MCL. He said, forget it. I'm going to keep, being an athlete. After that injury, this guy was winning stages at the Tour de France. Sloppy knee. So do you always need your ACL? No, you don't always need your ACL. The other thing I put in here is just these strains, these mean peak ACL strains. If you look, cycling is super low. Doing a squat is higher. Doing a quad contraction is even higher. Those are some of the things that you go through when you're doing the rehab early on. Cycling is a great exercise for ligament injuries around the knee. I don't think the guy who invented the bicycle understood it, 150 years ago, but I'm going to tell you, this is one of the best exercises you can do when you're rehabbing your knee. And the reason is, it's these low strains. You're going to blow out your ACL at a peak strain of about 7%. So all these are below that, but cycling is really below that. So, okay, so that's it for surgery. All right, for Julian, you're back.
Sorry if you're expecting Julian, it's actually Adrian again.
Adrian, sorry about that.
So now that we've reconstructed the ACL in our athletes, what to expect post-operatively. This isn't supposed to be all the nitty-gritty details, but I just want to kind of give you an overview of what to expect if your child or athlete needs to go through this. So immediately post-operative, day 1 through 3, you can see in this top picture, the knee on his left has lots of swelling and therefore will probably have lots of pain. So in the beginning, we're just trying to decrease both that swelling and pain. We're also going to focus on restoring full passive straightening. So these patients do not have gait impairment, so they can actually move that knee. Quadricep muscle activation. I'll also fight that you also should start to activate the hamstrings as well. Just kind of those muscles around, make sure that they don't atrophy any quicker than they already will. And of course, safe utilization of crutches. Specific weight-bearing status does depend on if it's a 3 ligament injury versus just a straight ACL. What we're talking about here is just straight ACL. A couple weeks out, of course, we're still going to really emphasize that protection of the graft, as Dr. Hayden mentioned. This brace that you'll see down in the right-hand corner is one of the braces you'll see in most of the athletes 5 to 6 weeks out from ACL reconstruction, and that's really to limit the knee motion when they're doing daily activities. We're also going to focus on increasing the range of motion very gradually, improving muscle activation, and restoring some balance. A little farther out, week 4 to 10, we're again slowly working on motion. These knees swell up so much right after surgery that it's like trying to bend a full balloon. We can't really bend it very well until we get that swelling out of there. So that really needs to be the first and foremost thing, and then we can work on knee motion. Improving strength, not only just around the knee, but around the hip, ankle, core musculature. These athletes usually go from very high level athletics 5 to 7 days a week to sitting on the couch, right? So we have to make sure we keep strength everywhere up. Improving balance, and all of this is really through a slowly progress and safely progress with therapeutic interventions. We can't really progress tissue healing along, so it has to go through specific phases of healing, and that's how the rehabilitation is focused. So that's why we have to kind of take our time with it. As you mentioned, you don't want to go play basketball 6 weeks out. At weeks 10 to 16 is when we can first start talking about advanced activity. Depending on if the patient has met all of the criteria, they can be progressed to a walk-jog program. Okay? We're talking 3 to 4 months out. So to put it in perspective, this athlete again goes from this high-level competition and then has 3 to 4 months of not doing any jogging, any true high-level cardiovascular. They may be bicycling, of course, but nothing that was probably at the level, right, that they were doing before. So at this advanced activity, we're going to slowly progress into some more light sport programs and working again on the balance and the motor control to have the stability at that knee. Weeks 16 to 20 or months 4 to 5, we're slowly starting to talk about more return to sport activities. It's not go out and play with your buddies, it's not go out and run the trails that you could trip on something and try to catch yourself on that knee and rupture your ACL again. Instead, it's very controlled environment, slow return to activity. And true full return to sport really depends on the extent of the injury, the surgery that was required, and the specific sport that that athlete's trying to get back to. This is not a one-size-fits-all. Every rehabilitation program has to be very individualized for that athlete, what they want to get back to and what their goals are, as well as what their injury really was. So quick overview, when you think about rehab, some kind of take-home messages. That lovely post-operative brace we saw earlier, it's going to be worn for about 5 to 6 weeks. I don't know about run, jog, but more think jog, walk program at 3 to 4 months. Sport-specific training, not even beginning in a controlled environment until 5 to 6 months. Duration of formal rehab, I kind of made this larger. Unfortunately, with different insurance companies, you may have to transition patients more to a home program quicker. And that's really the true reason why some athletes only get 4 months of formal rehab versus the 9 months that I would love to have with most athletes. Return to sport, 6 to 12, 9 to 12 is probably more the current research. We really don't want to rush these athletes back. There have been some research to support some of these fast rehabilitation programs, but unfortunately the more we go back to that, it's really not supported. Again, tissue healing is what we have to wait for. And as Dr. Hayden mentioned, that the current research does support up to 2 years until you're participating at the same level. So this is a long process. And then even after you complete all this rehab, you need to continue strengthening balance, agility to prevent future ACL tears. As Julian mentioned, your risk increases after 1. So we have to really work on prevention for those athletes. So what can we do, right? Why are we all here tonight now? Research significantly supports that these prevention programs can help reduce the rate of serious knee injuries among female athletes. But all of the successful programs are really multifactorial. As I mentioned before, all of those risk factors, including strength and the neuromuscular control, really play a part. So we want to look at those modifiable ones when we look at how to prevent these injuries. So the primary components for the successful programs have included an active warm-up, such as jogging or lateral shuffling. Stretching, strengthening, especially of those hamstring muscles. We keep mentioning hamstrings because those basically help put the ACL on slack rather than tension. Hip musculature, because of course if the hips are strong, they help orient where the femur or thigh bone goes, which then can orient where the knee goes. And abdominal and back musculature, the core muscles, as you can see with planks, for instance, can help stabilize the rest of the body when they're landing from high-level activities. Plyometrics. When you think plyometrics, you just want to think jump training, with emphasis on proper takeoff and landing control, with avoiding that knock-knee position, and soft landing, not increasing the force through the knee. Instead, we want to land softly on the toes and then rock back onto the balls of the feet, and even thinking about getting into a deep athletic position rather than being straight up vertical. And those will of course be initiated more with both legs and then progress to single leg, because these athletes will ultimately have to do single leg activities. And lastly, agility training. When you think about agility, you want to think about explosively starting, decelerating, accelerating, changing directions, right? When we think about sports, that's what they have to get back to, so we have to train for it. And most importantly, in my opinion, is feedback to these athletes. We can put athletes through these programs, but if we're just letting them jump around and do these agilities without giving them any feedback as far as how to avoid those bad knee positions and how to land safely, we could actually be doing more harm than good. So we really need to watch how we're administering these, and we'll talk about more specifics here in just a minute. So as I mentioned, I'm a total nerd, and so I stay up on all the literature regarding this. And really there's a variety of programs across the world. It's not meant to read all of this, but basically it shows on the left all these different programs, okay? They vary in the duration and the frequency that they're administered. Who administers them? Is it coaches? Is it a one-on-one trained professional? Huge variability. So thankfully, a systematic review by Noyes and Barbara Weston, the reference down there, published actually this year, found that there's these 3 injury prevention programs which significantly reduce the rate of non-contact ACL injury rates in females. So I say that quickly, but non-contact, because that's 70 to 80% of the ACL injuries, and females, because unfortunately they're at a higher risk. So what does the research focus on? The high-risk people. So the first one is sports metrics. That is a program which is completed on a one-on-one basis with highly trained instructors through a trademark program. There is a website on your resource handout that you can look at for more information regarding that one. And then this Prevent Injury and Enhance Performance, the PEP, and the Knee Injury Prevention Program, or the KIP, are both programs that are administered by trained coaches. So because that's more of our audience base tonight, those are the 2 that we're going to focus on. Exciting part about this, the relative risk reduction in these 3 programs range from 75% to 100%. So we're not talking 20% reduction, we're talking huge differences. So this is where we want to focus all of our time. On a side note though, because I see a lot of young gentlemen in our audience, is yes, the research is on females, but what's interesting about these programs is they can actually improve different athletic performance measures, such as jump height, agility, speed, things that we look for in our athletes. So there's no harm in doing these, as long as they're done correctly, as I mentioned earlier, no harm in doing these warm-up programs with all athletes, not just females of a certain age. So let's jump a little bit more into that first one I mentioned, which is the Prevent Injury and Enhance Performance, or the PEP program. Before you start writing down things, this is on your resource handout. There's websites to give more information. But basically, this is a 20-minute warm-up neuromuscular program. Research by Berdellenbaum et al. Was completed over a 2-year span from 2000 to 2002, in which they implemented this 20-minute warm-up program for female soccer teams in Southern California. And this was a prospective non-randomized trial in which they had control coaches just do their usual warm-ups, and then the intervention coaches complete formalized training about how to successfully implement this PEP program, and then all the coaches injury reported. And they also talked about how many athlete exposures they had. And the exciting part is that in the first year of this program, after statistical analysis between the intervention and the control groups, there's an 88% reduction in ACL injuries. In the second year, there was a consistent high percentage at 74% reduction in ACL tears. So to give you a little bit of an insight into what this program consists of, the components are a warm-up, stretching, strengthening, plyometrics, and agilities. Those kind of sound familiar, right? The resource handout does give a link to this field setup. So if you want to look into this more, just go ahead and look at that resource. But just, again, keep in mind that these are all coaches that have this additional training. The KIT program, or the Knee Injury Prevention Program, is again another 20-minute warm-up program. And similarly, in 2006, Labella et al. Implemented this 20-minute warm-up program in 46 Chicago high schools.
Sorry.
We're good. As part of a cluster randomized control trial. So again, we had a control group, usual warm-up, and then an intervention group where the coaches were trained on how to implement this KIT program, and then they compared results at the end on injuries. Most exciting to me about this one is that not only did this KIT program reduce ACL injuries by 80%, but it reduced knee sprains by 70%, ankle sprains by 62%, and even gradual onset leg injuries by 52%. We're talking 20 minutes at the start of your warm-up, right? That's all we're talking about exchanging out. So that's just showing that having proper form and proper movement patterns can not only reduce ACL injuries, but injuries in total. So again, your resource handout will have a link to this, so don't worry about reading all the specifics. But this is kind of how the KIT program is set up. Similar components to the PEP, including active warm-up, strengthening, plyometrics, balance, agility, and active stretching. So there's slightly different exercises on different practice days. And then on game day, they have an abbreviated version to complete. And then, of course, additional tips for the KIT program to help. A little side note here on your handout for the resources. Yes, I went to school in Chicago, and this is from Chicago, but I'm a little biased to this right now, just because of the resources on their website. As a coach and as a parent, you can go on, make your own little login, and go through a coach training program. So it kind of takes what we do tonight and reiterates it. So it doesn't have to be the only time you hear about it. So I would highly suggest checking out that KIT website. So now what can we look at as parents and coaches? So these list of 4 factors up here, research supports contribute to the vast majority of female non-contact ACL tears. Again, mechanism varies in males, but again, these programs can improve sports performance, so don't lose me yet. And so looking at these 4 factors, the first one being knee valgus, or a knock-knee position. So I'm sure many of you have seen it with female athletes where their knees will go in. I'll show more pictures, you can't see my knees right now. That can increase the stress on the ACL, contribute to an ACL tear. The second one is decreased knee and hip flexion. So a female that lands straight up in the air versus getting down into an athletic position. Those 2 positions vary the muscle activity and therefore can increase or decrease the risk of ACL tears. Single leg activity, or majority of weight on one leg, meaning we land from a jump and we preference one leg. That'll of course increase the stress through that leg. And lastly, center of mass, or basically center of the body away from the foot.
Leave it.
I've lost focus. So that basically means that if you land and your whole torso is over here, of course that's going to affect where your knee is going as well. So prevention must focus on decreasing these above 4 stresses by altering body position as well as movement patterns to avoid risk positions. To avoid at-risk positions. Another interesting side tip is some of the current research actually supports that ACL rupture will most likely occur within 40 milliseconds after initial ground contact, meaning that athlete does not have time to change where their body is after landing from a jump, landing from to cut or pivot. 40 milliseconds, less than half of a second, ACL's gone. So obviously we need to focus on prevention and movement patterns versus changing how you do the movements after they're already done. Okay, so try to remember these 4, because we're going to look at all 4 of them. So here I have a female on the left and a male on the right landing from a jump. So can anyone yell out some of the differences they see between those 2 photos? Straight leg. Okay, so let's look at the knee. I heard straight leg. So if we look at those knees, we can see that the female's knees, especially the one on the right, is a little bit more in that knock knee position. That can, of course, increase the stress on the ligaments and then increase the risk of ACL tear. Anything else? Anything else? Pardon me?
Hands forward.
I like that, okay, because that's probably in contribution to getting down deep, right? So if you have your hands up here, you're probably more upright. You don't really just go like this for balance, right? But if you get down low, your hands come out to counterbalance you. So we're going to go with that, and we're going to look at decreased knee and hip flexion. So if your athletes are landing straight up and down, you want to give them feedback. Get low, get your butt back, right? Make sure that you're actually using the largest muscle in your body, your glutes. You're not forgetting about it, okay? Sorry, third one. Balance. Okay, so on that, we'll kind of go off here. The majority of weight on one leg, is that kind of what you meant? So she's over to the right. Can you see that? Let me see this picture a little bit, but her whole body is to that right. A lot of females will have one leg more dominant than the other, and you'll see that in their movement patterns. We need to make more symmetry in their movement to decrease the stress on the ACL, decrease the stress on the knee in general, to decrease injury. Okay, who's the real overachiever? One last one. Torso. Wow, you guys are good. So for the biomechanists around here, the arrow is from the center of the mass of the subject down to their foot base. So again, kind of in this picture, we're talking again about how that mass is over her right foot versus being in the middle. So a lot of times that's due to deficits in core strength, stability, and coordination between the legs and the torso. We're almost there, I promise. ACL injury recap. So we want to think, one thing we haven't mentioned too much yet is it's most common in people less than 25 years old. So it happens at all ages, obviously, but these are our young athletes. So as coaches and parents, we really need to stress the importance of helping young athletes. At least 2/3 or 70 to 80% are non-contact, meaning there's nothing happening with somebody else, and you hear that lovely pop. Rehabilitation varies, 4 to 9 months. Either way, it's a long process, and you have to respect tissue healing during that process. You can't go back right when you feel good. And females, again, are more likely than males, but remember, these programs can help all athletic performance as well, so no reason to kind of persuade you females versus males. Psychological aspects, like Julian mentioned, it's not an easy road for these ACL reconstructions and rehabilitation. And of course, ACL injuries correspond to an increased risk of premature osteoarthritis, knee pain, further issues. So prevention is the key. And research supports it, so it's a really good thing that we can look at. So just a few of the resources, but please refer to your handouts so they're a little bit more detailed. This presentation is really intended to provide you with basic information and an overview of the current research regarding ACL injury, treatment, and prevention. By no means does this presentation provide you with all the information you need to prevent all these injuries. Hopefully these additional resources, especially that KIP website, sorry to be biased, but KIP website's really good as far as additional videos and additional descriptions regarding theirs. The PEP is also wonderful in the fact that they have detailed descriptions. And also don't forget about your healthcare providers in your community. So the three of us, as well as many other healthcare providers, can help you. Don't feel alone in this. If you have any additional questions, or if you would like coach training or individualized athlete training, I'm just kind of throwing myself out there. This is a huge passion of mine, so that's why I'm here tonight. So please feel free to contact me, but also there's other clinics in the area that have highly trained clinicians, so don't feel like you have to go only to me. But thank you very much, and I appreciate all of you guys coming tonight, and we'll open the floor for questions.
Believe it or not, they could not come up with anything conclusive that says stretching actually helps prevent injuries. If you talk with elite runners, marathon runners, guys coming out of Africa, and all they're doing is running marathons, those guys do not want to stretch. They want to use that elastic recoil and the tendons that they got to propel them down the road. So again, I think stretching is important. I mean, that's the dogma I grew up with. You got to stretch before you get started. But again, the research is a little inconclusive of just how beneficial stretching is.
Two quick questions, please. AJ, when you, if we go back to the video, say, I think it was Alexis in the video, and she was in the physiotherapist and doing side sets along and all that. Is part of that logic just to get balance in the muscle memory?
Absolutely, I'm glad you picked up on that, because really there is a balance component as far as if your body's over here, you're going to be more off balance, right? So it's kind of trying to train those athletes where their balance point is so they can have that symmetry in their movement and not feel off kilter. We also utilize a lot of mirrors of visual feedback. You can tell some people over and over that their knee is going in and they're not going to believe you, but they see it themselves. So relearning that muscle control also can use mirrors and balance.
And if I may, Dr. Hyden, just a quick question. Is it possible for an ACL, some degree of tear, to heal itself over a period of a couple of years with just logical physiotherapy and avoid the knife?
Yeah, so people can have partial tears. You can also have a complete tear, and if you examine that person early on, immediately after the injury, their knee will be very loose. Later on, you'll come back and examine them a few weeks later, and it's like, boy, what happened? All of a sudden, it doesn't feel like you have a torn ACL. More often than not, when that happens, the ACL is probably scarred down to the PCL, which lives in that same notch, so you get a relatively stable knee. If you have a partial tear, we will tell people, look, continue to participate in your sports as though nothing has happened. If you have a subjectively stable knee, in other words, as a patient, you say, well, I don't have any issues with my knee cutting and pivoting. Continue on. And there is a small percentage of our population. I don't know if you're old enough to remember a guy named Thurman Thomas, played for the Buffalo Bills, played in the NFL, one of the greatest running backs at that time, ACL deficient. Had a great career, did not have his ACL. So people can get by, it's a small percentage. Partial tears, we encourage people to continue on. Again, sometimes these things, if you examine them a few weeks down the road, that ACL is probably scarred down to their PCL if they have a sense of a stable knee on an objective exam. But it really comes down to subjective. If you have a partial tear and you've got a knee that feels unstable, you should think about fixing it if you want to have a stable knee, even though it's a partial tear. It really comes down to sort of that subjective sense of whether your knee is stable or not.